Good morning, everyone. So today, Monday speech classes will be presented by Dr. Christina from Sakra Hospital, and we have Professor V.K. Kapoor sir, Professor Kalayrasan sir, and Professor Venumadhav sir to moderate the session. You can go ahead, Christina. You can present.
Morning, sir. My patient is a 54-year-old female who is a resident of Jharkhand and a homemaker by occupation with chief complaints of bilious output from percutaneous drain in the right upper quadrant since the past 3 months. In the history of presenting illness, she has had a history of pain in the right upper quadrant, for which she was evaluated and diagnosed to have symptomatic cholelithiasis in March 24 and underwent laparoscopic cholecystectomy for the same on 12th March 2024. The duration of the surgery was around 120 minutes. The attendants were explained about the intraoperative difficulty. A drain was placed and there was no history of any perioperative blood transfusion or blood transfusion. On POD2, the patient had yellowish discoloration of the eye with no demonstrable output in the drain. She was, however, discharged on POD3 and the drain was removed and the patient was referred to a higher center for further management. Subsequent biopsy of the laparoscopic cholecystectomy was negative for malignancy. At the tertiary center, she was evaluated with a few blood investigation and imaging, and underwent an endoscopic intervention to elevate jaundice, which failed. And later, she underwent placement of a percutaneous tube under ultrasound guidance, wherein greenish fluid was drained, and following which the jaundice resolved. She was later discharged with the tube in situ and was asked to review after 2 months. At 2 months at present, she has been asymptomatic for the past 2 months, has a percutaneous tube, which is draining about 200 to 300 ml of greenish fluid daily. She gives no history of abdominal pain or fever, no history of loss of appetite and loss of weight, no history of any abdominal distension. I would also like to know what the color of the stools were, whether they were acholic or colic, and whether she had any history of any fat-soluble vitamin deficiency. She has no history of any medical comorbidities, and family history and personal history are not contributory. So to summarize, my patient is a 54-year-old female with no comorbidities, post laparoscopic cholecystectomy 3 months ago with intraoperative difficulty and prolonged duration of surgery and jaundice from POD2 with subsequent failed endoscopic intervention at a tertiary center and resolution of jaundice with ultrasound guided percutaneous tube placement, possibly PTPT. She has been asymptomatic over the last 2 months with approximately 200 to 300 ml of bile draining daily from the PTPT.
So, doctor, so they have suspected some intraoperative difficulty in surgery was also explained. Why do you think that has happened? Because basically it was not elaborated, but what do you think was the scenario?
When the patient was taken up for surgery, the diagnosis was a symptomatic cholelithiasis. I would like to review the ultrasound then. According to the history given to me, there was no anticipated difficulty before going in for the laparoscopic cholecystectomy. However, the duration of surgery was longer, is almost 2 hours. And I would also require additional details as in whether any additional surgeon had to be called in for any additional opinion was obtained. If there is any intraoperative bleeding or bile leak that was noted intraoperatively. And I would also like to review the OT notes and OT video also, sir.
So, Dr. Sna, why you mentioned as query PTBD?
It was a percutaneous tube that has been described, but the jaundice has been elevated. POD2 jaundice has been elevated over the last, after the placement of the tubes. So it's a possibility that the tube was a PTBD.
So in what setting in the acute phase do you think a PTBD would have been placed?
When there was a suspicion of complete transection, also given the history that the endoscopic intervention had failed, which could possibly mean that there was a complete transection of the CBD or the CHT.
I mean, so in any setting of complete transection, you will do a PTBD?
No, sir. No, sir. I would when there is a complete transection with the background of cholangitis, I would prefer to do a PTBD.
No, I think you understood the question. Maybe I'll make it more specific. Bile duct transected, okay, not
Yes, sir.
clipped,
Yes, sir.
transected and clipped.
Yes, sir. So
What do you think is likely in this patient?
bile duct clipping is what I'm thinking, sir, because of the early jaundice.
What is the most likely percutaneous tube to be placed in a patient who possibly has a bile duct injury?
Tube
Is
to
it-
drain any collection if present, sir.
So it is a percutaneous catheter drainage PCD of a biloma
Bile.
rather than a PTBD.
Mm.
PTBD also can be required, but
Mm.
more likely is a percutaneous catheter drainage to drain a bile collection.
Yes, sir.
So doctor, this patient, if you
Yes,
see
sir.
the post-operative course, you said she developed jaundice. So what would be your approach in this patient when you're dealing with such patient has come and then?
Sir, if I'm in a tertiary center with available advanced endoscopist and a good interventional radiologist, I would first evaluate the patient with blood investigation, blood count and LFT, and a creat also in case I require a CT. I would do an ultrasound to first look for any collection and later do a contrast enhanced CT. In the contrast enhanced CT, I would look for any collection, any ascites, and the level of transection, any clips if present, location of clips, and if any vascular injury, I would like to address that also, sir.
No, in this case, she developed some jaundice, and so how do you approach a patient with jaundice, post-operative jaundice? And obviously, she didn't have any fever or this symptom.
Cholangitis.
She developed with jaundice. What are the possibilities, and how would you proceed? How would you evaluate?
So the possibilities of a complete transection without clipping. So on CT, I would like to look for the level of transection, proximal biliary dilatation, and if there is any bilio digestive continuity, sir. And if there is any continuity, I would attempt ERC. If there is no
one
continuity.
cause of jaundice, you are talking about jaundice immediately post-op after a cholecystectomy. One you said complete clipping is one possibility, because complete transection may not develop with jaundice, so they will then with peritonitis, biliary peritonitis and all, isn't it? So we are talking about scenario where she developed without fever or anything, but she developed jaundice. And one scenario you said is complete clipping. Are there any other possibilities?
Other far possibility would be CBD calculi, sir, which was missed preoperatively.
What is the commonest cause of post-cholecystectomy jaundice?
Slipped CBD calculi, sir.
It is the CVD stone. So that has to come immediately when this question is asked, that how do you approach a patient with post-cholecystectomy jaundice? Go to your first slide, please. Before this, yeah. So I and many other examiners would prefer that cholecystectomy should figure in your chief complaint, because otherwise it becomes very difficult for us. Many examiners are fond of stopping at this stage and asking you, what do you think, as soon as the patient says this. So I would prefer here saying that on the bilious output from a percutaneous drain placed in the right upper quadrant since 3 months following a laparoscopic cholecystectomy whenever it was done. Okay.
Yes.
Go to the next. Next. Again, some examiners are very insistent that your history should be as you have asked the patient or as the patient has told you. So did you ask the patient, do you have a history of fat-soluble vitamin deficiency? No, you don't. What questions do you ask?
I would ask if there are any bony pains, if there are any coagulopathy like ecchymosis or easy bruising, and night vision difficulty in night vision.
So what I'm trying to say that in the history, many examiners would insist that you use the terms and the language which you would 2, then you are taking the
Observation.
history from the patient rather than technical terms.
Yes, sir.
Now, what you said that an endoscopic attempt was made, but it failed. What do you interpret out of that?
One possibility is that there is a complete transection on the cholangiogram that is performed before any attempted stenting. The other possibility is that the stenting could not be done because of the size of the injury.
Yeah, so what I'm trying to hint at that although most likely possibility is that there is transaction or no ductal continuity, but it may be possible that the endoscopy has failed because of other reasons. Is the reverse also true?
Yes, sir.
Could endoscopy be successful even in presence of a complete transaction?
Yes, sir. If an early endoscopy is done, if the ducts are in close proximity, it can be possible.
So an expert endoscopist, especially in a very early post-injury phase, can bridge even a complete transaction, although in most of those cases, a rendezvous approach, which means that there is a percutaneous guide wire passed, which goes into the distal CBD, which is retrieved by the endoscopist. Now, at some stage, you said that you would like to review the pre-cholecystectomy ultrasound. How does it matter now? The injury has already occurred. How does the pre-cholecystectomy history, LFT or ultrasound matter now?
MR or a CT was done, I would look for any biliary variants.
How does it matter? The injury has already occurred.
It doesn't.
Does it or does it not? It matters because as we discussed earlier, common cause of post-cholecystectomy jaundice is still CBD stone. It is not biliary stricture. We have to remember that because CBD stones don't come to us, they go to medical gastroenterology. But it is still the commonest cause of post-cholecystectomy jaundice. So in the early post-cholecystectomy period, if there is jaundice, you need to review the pre-operative history, which means history of recurrent episodes of acute pancreatitis, cholangitis. You need to review the LFT, whether there is any evidence of biliary obstruction. You need to look at the ultrasound, whether there was any IHBRD, dilated CBD, suspicion of a CBD stone. You need to look at the intraoperative findings, whether the gallbladder contained multiple small stones and whether the cystic duct was wide. All these would increase the possibility of a stone slipping down the cystic duct into the CBD and causing post-cholecystectomy jaundice. Because in the post-operative period, especially early post-operative period, if you strongly suspect a CBD stone, then you could go for an early endoscopic intervention. On the other hand, if you do not suspect a CBD stone, then as we will discuss later, depending on your approach, you may wait for an endoscopic intervention.
Yes.
Yeah, please proceed.
On examination, the patient is conscious, cooperative, and oriented. The BMI is normal. The patient is well built and nourished with good performance status and good breath holding time. She has no pallor, no icterus, no cyanosis, clubbing, lymphadenopathy, or pedal edema. Vitals are stable. Patient is afebrile, and she has no signs of dehydration, liver cell failure, or any visible scratch marks. On abdominal examination, the abdomen.
Go back. Now, I know that most of the students follow the PIXEL acronym to describe these findings, but I would prefer if you mention the important, the relevant negative finding first. So in this case, icterus is the most important finding.
Yes,
so
sir.
icterus should come first. In surgical cases, cyanosis is not of much importance, but you all are fond of mentioning cyanosis before, for example, in a patient with suspected malignancy, most of the students would mention cyanosis before lymphedema, lymphadenopathy or edema, but I would prefer that the important negative findings are mentioned first and the less important or less relevant findings are mentioned later.
Yes, sir.
I think Dr. Yadav has a comment to make. Let us read that. He says, half-life of vitamin A is much, so one cannot expect night blindness so early, and there is a reserve of vitamin A. TD, would you like to come in and make a comment on that before we proceed? Is it related to the duration of biliary diversion?
Yes, sir. It's so early. I mean, in a few weeks, usually vitamin A deficiency doesn't occur. So if we are seeing so many of there is reserve of vitamin A, we are seeing so many of bile duct injury. Hardly ever anybody has noticed night blindness, and even in malignancy cases, people come so many months after the complete block of this thing. Still, hardly ever we notice night blindness because of the simple reason that there is a store of vitamin A, and the high lipid is also vitamin A is much. So that's why usually vitamin A deficiency is not that common in a bile duct diversion or even bile duct obstruction.
Yeah, I remember that in our very large experience of more than maybe 1,000 patients with biliary injury seen at SGPGI, in my own experience, I remember only 2 patients, but I don't remember what was the duration of the injury in those cases. Yeah. Okay, please proceed.
So the significant negative findings in my general examination would be that the patient doesn't have any icterus, doesn't have any signs of sepsis or dehydration or liver cell failure. And the positive things are that she is well nourished and the performance status is good, sir. On abdominal examination, sorry, it's a lag. On abdominal examination, the abdomen, there is no significant finding except for a PCD that is noted in the right hypochondrium with draining 150 ml of bilious output in the back. The palpatory, there is the abdomen is soft and non-tender. The liver span is normal, and on distal rectal examination, the glove is stained with pale color stools with normal sphincter tone. The other systemic examinations are unremarkable. So to summarize, my patient is a 54-year-old female with no comorbidities, post laparoscopic cholecystectomy 3 months ago with jaundice from POD2, subsequent failed endoscopic intervention at a tertiary center, and resolution of jaundice with ultrasound guided percutaneous tube placement. And the patient has been asymptomatic over the past 2 months with around 200 to 300 ml of per day of bilious output in the drain. On examination, she is well nourished, is of good performance status, has no signs of sepsis or cholangitis, has a PCD in the right hypochondrium draining bile. She has no icterus, but however has pale colored stools on rectal examinations.
You have used 2 contradictory terms in your summary. In the history, you say PTBD. In the examination, you say PCD. I hope all students understand the difference. PCD is a percutaneous catheter drainage, as I said earlier, placed in a bile collection in the peritoneal cavity, whereas PTBD is a catheter placed transhepatic into a bile duct. So you have to use the same, whatever you think, you have to use the same. As we discussed earlier, it is more likely to be PCD rather than PTBD because the first aim of management of a bile duct injury with bile leak is to drain the biloma. Now, there is a history of 2 months and you are saying about 200 to 300 ml per day. In any such case, you should be more, you should elaborate more on what is the course of this external biliary fistula. Whether the output per day is gradually increasing, static, or decreasing. And we will discuss why that is important later when we go to the management. Second is, when you say that there is a tube in the right hypochondrium which is draining bile, you also need to tell us more about the nature of bile. So you need to tell us about the color, the consistency, whether it is clear, golden yellow, or greenish yellow, whether it is turbid. So all that is important for the management. And Dr. Yadav asks, how do you explain that there is only 300 ml bile in the tube, but the stool color you said is still pale?
Loss of biliodigestive continuity, sir.
But then
is the possible cause that
yeah,
the icterus has resolved, but still the pale colored stools are persistent.
So if there is complete diversion of bile, do you expect only 200 to 300 ml per day of bile coming out?
So higher.
It should be much more than that, isn't it?
Yes.
So that is what his question is, that this cannot be explained. And there are occasions in medicine where you can't put 2 and 2 together and explain everything. So if you can't, you have to say that, no, it is something which cannot be explained and I don't know what is the reason. It doesn't fit in. If it is a complete diversion, the amount should be more. If it is If there is still some continuity or there is an internal fistula, then stool color should be normal.
Yes, sir.
Okay.
So I think with the information you have, you think it's more likely to be a transaction and clipping, right?
Yes, sir.
I think
Yes, sir.
probably that made you to think it as PTBD rather than a
PTBD.
PCD.
Yes, sir.
Because there are some features which usually do not happen, like patient had jaundice and resolved after placing the tube, which is usually not a scenario if it is a percutaneous drain of glioma. So that is something which you cannot explain by a PCD. So I agree with that. I mean, going by whatever you described, so a PTBD would explain the clinical findings, what you have, rather than a PCD. So I think you have the information. This is the information you have. So in that scenario, so generally how you proceed?
I would like to evaluate the patient, sir, with blood investigation and imaging simultaneously. In blood investigation, I would like to
No,
get a.
before you try to evaluate,
Yes, sir.
whenever you have a patient
Yes, sir.
with a post-cholecystectomy, a suspected bile duct injury, generally what you do, I mean, in your practice?
Sir, I would
Patient
first.
operated elsewhere.
Yes, sir. I would like to review the video of the surgery done elsewhere. I would like to talk to the surgeon who is done. I would see if there are any aberrant vascular anatomy, aberrant biliary anatomy, and anticipate the same in my management. I would also look if there was any bile leak during the surgery, any bleeding that was noted during the surgery, and time of surgery also, sir. And what kind of energy device was used during the surgery.
Okay. Can we have the intraoperative findings?
Yeah, if you have that, you can, yes.
You just have intro findings, sir.
Yeah, absolutely.
It was given to me that the family was counseled regarding difficult surgery. No notes were available. GB was fibrosed with frozen calyx and lots of cicatrization at the porta. By careful dissection, the cystic artery and cystic duct were identified, clipped, and ligated. While dissecting from the liver bed, a leakage of bile was seen from the accessory duct, cholecystohepatic, with leakage of bile, so ligated and clipped. Hemostasis done and closed with ADK.
So what do you think would have happened?
CVS, it was fibrous gallbladder with frozen calyx. CVS was not achieved according to the given here, the data given here. Cystic duct and artery were identified according to the surgeon's perspective, and leakage of bile from the cystic.
Your interpretation based on, so this is what the surgeon, I mean, it's a usual scenario. This is what generally the operating surgeon tells that, because usually it often happens due to the misinterpretation. So what is your interpretation of this finding based on the current clinical findings of the patient?
Based on the, I would like to see if the cystic duct that was ligated according to this was actually the cystic duct or a major bile duct in itself. And the leak, there is also a leak, sir. But the patient didn't have
when
any
you face an intraoperative problem like this, how do you proceed? Like you have seen some bile coming. So how will be your approach?
I would first like to see from where the bile is draining. If it is only from a very minor duct at the cystic bed, I would.
How do you know it's a minor duct? So
depending on the amount of bile that is leaking, sir, I would place a drain in the subhepatic space, sir. And if it's a minor leak, I would ligate it, sir.
No, how would you know a minor leak or major leak if some injuries happen?
Yes, sir.
So, would you still like do what he has
No,
done?
sir.
Would you
No, sir. I would only place a drain and come out, sir.
So what Dr. TD also is saying in the comment box, and what I also would like to say, that this is the classical example of a misinterpretation of the anatomy. What the surgeon initially thought to be the cystic duct and
Cystic.
cystic artery were actually the CBD and probably the right hepatic artery, which he clipped and divided. And then he encounters another duct, which he feels is a cholecystohepatic duct.
Cholecystic.
But that is probably the proximal bile duct, which is got divided and he has clipped. So this is what is known as the classical laparoscopic bile duct injury, where a segment of the bile duct is excised along with the gallbladder specimen. And in answer to the earlier question, that how do you decide whether to clip a duct or not clip a duct? Most people would go by the size of the duct and also the location of the duct. If the duct is about some would say up to 3 mm in diameter, and it is away from the hilum, it is in the gallbladder bed, then you can probably clip it. But if it is a 3 or more millimeter diameter duct and it is more towards the hilum, then you think or consider it to be a significant duct, and then you don't clip it. If you have the expertise, as we will discuss later, you can try to do a repair at that time, or you drain and try to convert it into an external biliary fistula and decide when and whether to repair. So
Will you do an intraoperative cholangiogram in such a scenario?
Sorry, sir.
Will you consider an intraoperative cholangiogram?
But if I have the facilities for it, yes, I would consider an intraoperative cholangiogram.
How it's going to help?
It would give me the location of the injury and to decide further whether I have to place or drain, convert into external biliary fistula and come out, or if in case expert biliary surgeon is available, to plan for an intraoperative repair when the patient is stable.
Although you must add that doing an intraoperative cholangiogram, in addition to the problems of logistics and the quality of image, is how to do it, because the gallbladder has already been removed. So you will have to put a catheter or a tube into the divided duct and inject the contrast, which in itself may be a tedious exercise for any less experienced laparoscopic surgeon, and attempts to do that may cause even further injury to the duct. So yes, you can do it. It is good, but it has its own issues.
Yes.
Okay, let's proceed.
Sir, I would like to look at blood investigations, complete blood count, LFT and INR along with the creatinine.
So what most literature has shown, that intraoperative cholangiogram may or may not help to reduce the risk of
injury
bile duct injury, but if it can be done, it helps you to identify the type of injury and then decide the intraoperative management.
Or on LFT prior to PTBD, there is direct hypobilirubinemia with elevation of ALP and elevation of and transaminitis also. The INR is 1.32, sir. Current LFT, if I can have. The recent LFT shows normal bilirubin levels with elevated ALP, albumin of about 4.2 and normal INR also, sir. No transaminitis is there. CBC and creatinine. The CBC, there is no anemia, the total counts are normal and the platelets are also normal, sir. And creatinine is also normal for this patient with normal electrolytes also, sir. I would like to proceed with a MRCP to look at the location of the injury, the proximal biliary dilatation and the extent of discontinuity if any is there. along with a CECT to look for any concomitant vascular injuries.
You have a PTBD tube in C2. Is
Yes,
there
sir.
no other way to get a cholangiogram?
Yes, sir. I would prefer to do get an MR because it would give me a complete picture, and PTBT might also increase the risk of cholangitis. So I would prefer MR over a PTBT-gram.
Is that the only reason why you would not do a PTBT? Risk of infection? You take all aseptic precautions?
Also, if there is any isolated duct that can also be that will be missed on a PTBT-gram, whereas MR would include that.
Only aberrant duct, no other problem with PTBD? Does it, whether PTBD gives you the complete information or not, depend on
If
the
there's
time?
if there is an isolated ductal system that has been away from the PTBT draining areas, that would not be included. So.
Suppose it is a bismuth type 4 stricture. There is no isolated ductal injury. There is no aberrant ductal injury. Then also PTBT gram would not show you both the systems, isn't it?
Yes.
So your answer should be that I want a complete evaluation of the entire intrahepatic biliary system and the level of block, which in certain type of biliary strictures, that is type 4 and type 5, that information may not be available with a PTBD gram. So that is why even if there is a PTBD, I would prefer to do an MRCP. Somebody may say that I will do a PTBD gram first, and if all the ducts are well seen, then probably an MR cholangiogram may not be required. And of course, the other point you mentioned, but as Dr. Yadav says, that once you have a PTBD, how can you have, why should you be worried about cholangitis? Because the treatment of cholangitis is PTBD.
PTBT, yes.
So taking all aseptic precautions and then again draining the tube out, you should not ideally have cholangitis following a PTBD gram. Yes.
Yes.
What imaging do we have?
So we have MRCP, which is done before insertion of PTBT.
Okay.
Will you do an ultrasound before an MRCP to rule out any collection? There could be some bilioma there because it's very rare that it's the transected duct is completely clipped. And even if it is clipped, there is very high chance that clip might slip and there can be a small bilioma which can interfere with your MR finding. So will you do an ultrasound before doing MR or you will directly go ahead with MR?
So in this patient, I would prefer to go ahead with an MR because my patient has been stable, has had no fever. The labs are all normal, sir. So I would directly go away with the MR, sir.
Okay.
Yeah, but that is important. If you think or if you suspect that there could be a bile collection, then it is advisable to drain it first and then do an MR cholangiogram, because otherwise the biloma, which is usually in the subhepatic area, would interfere with your evaluation of the biliary ductal anatomy, which is the aim of doing the MR cholangiogram.
I don't have the control yet.
You have controls now.
On the reconstruction image of the coronal section of the MR. There is bilateral IHPRT with crowding of ducts at the hilum. There is possible loss of hilar continuity also. Sir. I would
What do you mean by crowding of ducts at the hilum?
dilated biliary radicals of the hilum, so second order branches, first order and second order branches.
No, because the crowding is a term which we generally use when we use it.
Not in case of biliary injuries, sir. In case of any malignancy.
No. In what setting you use the term crowding of ducts? When it happens, actually. No, that happens with the subtrophy.
Yes, sir. Yes, sir.
This is a present PTB diagram or done before PTB?
Before the PTBD, sir.
So this is
Pre-intervention.
post-op, which post-op, it must be post-op death.
Within the first week of
Okay.
surgery, sir. Fat suppressed T2 images shows ascites, some minimal collection. Bilateral IHPRT is there. There's some fluid collection at the GP bed. I'm able to see the distal CPT up to the supraduodenal level, beyond which it's not clear. Superiorly, I'm able to control.
So what is your interpretation on this MRCP?
So it looks like a E5 type of injury, sir, wherein the confluence is lost.
E5,
Sorry, not E5, sir, E3.
E3 or E4?
E4, sir. E4 type of injury where the confluence is lost, sir.
Can you show us the cholangiogram once more?
Of hilum, sir. There's no proximal CBD stump that I'm able to make out, sir, and the right and left ductal system seem to be separate, yes.
So this is only one
So
section.
you have, okay, yeah, please go ahead. Please go ahead, doctor. You're asking something.
Yeah, you have to see the multiple sections, especially in MRCP, you can't comment on one section. So telling it's post 4 or 3 is very difficult with whatever you've shown. Because you have to rotate and see. And also the collection may be interpreting with your interpretation, isn't it?
Yes, sir.
So this patient was seen and this MRCP is done, then what would you have done next step, the next step? You said some collection is there in the GB fossa and the dilatation. Confidence
Yes,
you're
sir.
not able to see.
Yes, sir. I would first drain the.
Sorry, before that, if you were the treating doctor, would you have got an MRCP done on day 2?
No, sir.
Why
No, sir.
not?
I would first get an ultrasound, look for any collections, drain that if when feasible, and later on evaluate the patient and get an MR, sir. Immediate post-operatively, there would be fluid collection and inflammation, which would obscure the findings.
No, sir's question is you do normally do a CT scan, but when you do an MRCP, is there any role for MRCP in the early period? On which conditions would you do an MRCP?
In the early phase, if I'm in a tertiary center and I'm planning for an early repair, I would do so.
No, not only a big. So this patient present with jaundice, taking this patient into consideration jaundice, and he had history of stones, and he was expecting CBD stones, and there's no collection on ultrasound. In that case, an non-invasive MRCP would be helpful, isn't it? But otherwise, generally, these patients were present with collections and also MRCP may misinterpret. So usually we do a CT scan, which may also show the level of cutoff, everything, all the information we'll get.
So would there still be a situation where you would do you said you wouldn't do an MR, you would do an ultrasound. If there's a collection, you will drain it. I will add to that if clinical suspicion of a collection is strong and ultrasound doesn't show a collection, then you would go ahead and do a cross-sectional imaging, which could be CT or MRI. But suppose patient is otherwise all right, there is some icterus or hyperbilirubinemia. Would there be an indication to do an MR in the early post-operative period? I would say even day 1.
In case there are any undrained segments, to look for that, I would do an
Okay. What I was hinting at, that if you believe in the philosophy of an early repair, and as we know that early repair is extended in the post-operative period also, or I would say immediate repair. Immediate repair is intraoperative, and some
first 72 hours.
Plus 24, maybe 48 hours, depending on the clinical condition. So if you are planning to do an immediate or an early repair, then obviously an MR would be required, because you can't or you don't want to go ahead with the repair. And when you are reading an MR for a acute bile duct injury or a biliary stricture, you should you do definitely mention the type of stricture, which it was not appropriate that you faltered from 5 to 3 and then came to 4. You should have straight away said type 4. But before you say type 4, you have to carefully look for any aberrant anatomy, because that would make it type 5 if both the main duct and the type and the aberrant duct are involved. And you should also comment if you are thinking of a immediate repair, that there is a good length of loss of segment of the bile duct here, which means the bile duct has been excised. And in the later phase, when you are reading the MRCP, you should also comment on any evidence of indirect evidence of a vascular injury in the form of atrophy hypertrophy
complex.
Okay, please proceed. Please answer the question.
Yeah. This is pre-PTPD, right?
Yes, sir.
So this is the finding. So what will you plan? Where you place a PTPD in this case? You have the MR finding. So what do you tell your IR team?
I would plan for a right PTPD initially, sir. Look for communication at the higher level. Determine definitively if it's a type 3 or a type 4. If it's only a type 3 injury, I would continue with only right PTPD, sir.
So why not left side? Why right side?
Both ductal systems are dilated in this patient, sir. And anything would be fine, sir.
No, but that's what the IR team is saying. Both ducts are dilated. You have any preference which side I should drain?
If preference, I would prefer to do a left PTPD, sir. Would help in intraoperative identification also, sir, when I'm planning to do a side-to-side anastomosis.
So you have difficulty in identifying the left side duct intraop.
Which duct is more difficult to identify intraoperatively?
Right, sir.
So if at all you need a catheter in a duct to identify it intraoperatively, it is right rather than the left.
Left. Okay, sir.
Okay, so now you will do a PTPD cam?
Yes, sir.
So in this case, which side it was drained? So do you have the information as of now or?
Right.
Okay.
Right.
So, in your opinion, was there an indication of a PTBD?
Yes, sir.
What was the indication?
Complete transaction with loss of segment leading to dilatation in the early postoperative period itself, sir.
So, post cholecystectomy, if you have a clipped duct and there is no major bile collection in the peritoneal cavity, patient has developed jaundice, these patients would require or would have a PTBD. Is PTBD the intervention of choice? What would PTBD do? Yes.
PTBD would drain the bile ducts, reduce the
Why do you
chances of
want to drain the bile
cholangitis.
duct? Why do you want to drain the bile duct?
To alleviate cholangitis, sir. That's all.
Was there cholangitis?
No, the patient didn't have any cholangitis.
That's what I was asking. In this patient, she never had clinical cholangitis. The only indication of PTBD in a patient with complete transaction of the bile duct would be uncontrollable cholangitis, which means if the patient presents to you with cholangitis, you first treat it with antibiotics, preferably parenteral. If there is no response within 24 to 48 hours, that is the only indication of PTBD. The other is what is known as, it is called PTBD, but we at SGPGI always said it should be called PTBC, percutaneous transhepatic biliary catheterization, which is done just before surgery for intraoperative identification, where cholangitis is not the indication. So that is done just before or just on the day of surgery, or some groups would even do intraoperatively under ultrasound guidance. So in this case, there was no indication. A complete transaction is not an indication for PTBD. It is complete transaction with cholangitis, which is the indication for PTBD. Yeah.
Was there an indication for early repair in this case? Patient didn't have any cholangitis, no fever, MRCP, as you said, there's nothing much, complete cutoff is there. Would you consider an early repair in this case? You consider what all first?
Sir, I would prefer to do a delayed repair because I do not know if any vascular injury is there. I would wait and allow the stricture to settle down because strictures can ascend proximally, and that would give me a dilated system to operate on.
No, you listen to the question. So this is a MR done in the immediate post-op, right?
Yes, sir.
So you have a dilated system.
Yes, sir.
So with this finding,
yes, sir.
If the patient was referred to you that time, you would have considered
sir.
early repair, and then you justify your answer.
Sir, I would not have considered early repair, sir. In case I'm planning for an early repair, I would like it to be done by a biliary surgeon with the expertise.
Assume that every expertise is available and it's a good
Expertise
step.
is available. Okay, so that's
Yes, sir. Yes, sir. I would go ahead and do an early.
What are the
repair,
points
sir.
which are not favoring early repair in this case? As you said, two or three points, or what are points in favoring? You said you would want to do, but why?
Sir, points favoring early repair would be that the system is fully dilated, even though there is we are not sure about the loss of hilar continuity. We can always intraoperatively explore and make anastomosis.
No, loss of hilar continuity. It's not there again.
So for example, if you are planning
yes,
for early repair, what additional information you require in this patient? You have an MR finding?
Yes, a CCT to look for vascular anatomy and injury, sir.
Yeah. You can't look at the vascular anatomy on MR?
I can, sir. Contrast enhanced MRCP can help, sir.
So that brings us to another issue with the point we were discussing earlier, that when would you do an MR in the early setting? One of the reasons would be if you believe and if you want to do an early repair or an immediate repair, then it is important because to know the vascular status, injury status, because even those groups which believe in early repair, they say that presence of a vascular injury is a contraindication for an early repair.
Early repair.
That case, vascular assessment is extremely important, mandatory, and then either ideally you should do an MR imaging, MR cholangiogram, and MR angiogram. And that answers the question asked by one of the students that if you believe in early repair, then you have to assess the vascular. If you believe in delayed repair, which is after 4 to 6 weeks of injury, then vascular injury is not of much importance. We'll discuss it later. But for an early repair, it is important. So coming back to the question which Dr. Venumadhav was asking, even if you don't believe in early repair, what are the exceptional situations where you would consider a possible early repair? What are the
Stable patient with no cholangitis, no significant collection.
What do you mean by stable?
A patient not having fever, vitals are stable,
That
no
is not
signs of any
stability.
cholangitis,
Stability,
no organ.
word stability we use usually in relation to hemodynamic status. You should say sepsis-free patient.
Yes.
There is a difference between stable patient and sepsis-free patient. Here, the requirement, obviously, there is no bleeding, so we are not talking of stability. We are talking of septic status. Yes, go on.
Yes. So a patient who is sepsis-free and with no collection in the with good performance status, no significant comorbidities that would affect another that would be affected by another anesthesia, and with available expertise, I would prefer to do early repair.
So the ideal conditions or situation for an early repair are post-lap chole. I'm saying lap chole because if it is open chole, there is possibility that adhesions may be there. Although if you're going in within 24 to 48 hours, that doesn't matter. I'm talking of early repair now within a week or 10 days. Clipped duct, completely clipped duct with no bile leak, no biloma on any cross-sectional imaging, no sepsis, either in the peritoneal cavity or in the biliary tree, no peritonitis, no cholangitis, further documented by investigations also. Favorable anatomy. Favorable anatomy means Bismuth type 1, type 2, or a good type 3 stricture. Now, we at SGPGI, when Dr. Sikora was there, we classified type 3 also into good or bad. Good means that the confluence is forming and even the floor of the confluence is
intact.
Whereas a bad type 3 means that, yes, technically there is a communication, but it is a narrowed communication, which means even the confluence is involved in fibrotic process. And we felt that these bad type 3s are as bad as a type 4. So only type 1, type 2, and a good type 3 with no vascular injury. And the other conditions, the patient-related conditions, that would be the ideal situation for an immediate or an early repair. And that is why all this assessment is very important. Now here, you are right, it appears or it is a type 4 because in no rotation, the two ducts are joining. And this is going to be a technically demanding repair. So even those who believe in an early repair may or may not take up this case for an early repair. We'll discuss how to handle a type 4 stricture later. Yeah, Venu, please proceed.
Yes, so this case, this MR cholangiogram is not a very ideal candidate for early repair because, as you say, it appears to be a classical injury. There's lots of bile duct because obviously it's going to influence and there's a bilioma, and you don't want to go in drop and then dissect higher up and cause more damage. So apart from comorbidities, anatomy itself is not very ideal. Another situation where there's one very good ideal situation is there's no contamination, just a clip and no transaction at all and no tissue loss. That is very difficult to find, but that is one situation where definitely would consider. And of course, with vascular injury, we're still thinking a classical bile duct injury may have happened in this case. Okay, can proceed from the forward. So after this is done, and now we come to this situation where 3 months is over, 2 months is over, and now what you want to do now?
I would now that I know the level of injury, at follow-up, I would like to do a PTPD-gram to look at the status of the ducts and plan for surgery.
What you are specifically looking for in the PTPD-gram? Status or duct means?
Dilation of the ducts. because a dilated duct would mean that the anastomosis would be easier, and in a undilated duct, because of PTBD, the anastomosis might be difficult.
See, why you want to answer?
And
You
yes,
have a
sir.
PTBD.
Yes, sir.
So in a patient PTBD, you expect
It would.
what you're
Yes, sir.
specifically looking for in a PTBD gram? It's a very specific question in this patient. So you have the MR pre-PTBD. So if you want to do a PTBD gram, what you are specifically looking for in this patient? It's not about duct is dilated or not. So when you do a PTBD, obviously the duct tends to collapse.
Yes, sir.
What you're specifically looking in the PTBD gram in this patient?
The lower extent of the injury, sir.
So what is this is a type 4 according to MR?
Yes, sir.
MRCP? But
Yes,
what
sir.
is the possibility? So how often MRCP shows type 4? Introp it is type 4. Is it 100% specific MRCP typing?
Does the clinical course of the patient after PTBD correlate with the MRC
No, sir.
findings?
No, sir.
It doesn't. That is what Dr. Kala is hinting at. See, MRC showed a type 4 stricture. You have done only one side PTBD. The bilirubin has returned to normal. Is that expected?
So there's still a possibility of type 3 injuries where the hilum is intact.
How does that happen? That MRC shows a type 4, but actually it is type 3. How and why does it happen? And reverse also. Yes.
MRCP is a single shot image, sir, whereas a PTBD gram, the dye would be injected against pressure, which would more clearly define the hilum, sir, in this case specifically.
So MRCP visualization of the duct is based on presence of bile, which is fluid inside the duct. If at any point the bile has been replaced by a solid material, and what is that solid material? Sludge.
Sludge.
Then the duct would not be seen. So that is the reason, the most common reason why MRCP shows a higher type of stricture, whereas it is not. So if there is a sludge ball sitting there, that would appear as if the ducts are not joining. On the other hand, if you see two ducts overlapping each other, it appears as if they are joining, but actually they are not joining. So that could be an underestimate of the type of biliary stricture on MRCP. That is why it is very important to rotate the images in all directions and consider the worst case scenario. Yes, please proceed. So do we have a
PTBD gram of this patient?
We have a repeat imaging.
I think he was showing the PTBD gram.
This was done at the time of insertion, sir. We don't have any repeat PTBD.
No recent imaging in here.
Okay. Ultrasound, sir. Yeah, and CT was an out, sir.
Let's have a look at the CT.
Suppose inhibitor collection in the right subphrenic space with a few air foci. No IHPRD. PTBD is noted in situ in the right hepatic duct. The vascular hepatic artery, portal vein, and the splenic vessels are normal. Portal vein is normal at the porta.
Do we have
no ascites or other solid organs?
The images? Can we see the images, please?
Sir, this was an outside, sir. We don't have any images.
Okay. So what's your plan of management of this patient at this stage?
I would like to drain the collections. There is a post-inhibitor collection in the subhepatic space with the air foci. I would like to drain the collections initially.
Why you want to drain that?
There is mention of air foci in it, sir. In case if it's infected, I would like to drain it out before planning any definitive surgery, sir.
So how often it is easy when there is a air foci under ultrasound guidance, you will be able to drain it.
So what is the location of this collection?
Right subphrenic space, sir. Sorry, sorry, I would like to.
Yeah, it is subphrenic.
Is this a recent CT?
Yes, sir. After 2 months of.
But currently, clinically and investigation wise, you said that she doesn't seem to be in sepsis. Isn't it?
Yes, sir.
She has no fever, counts are normal, neutrophils are normal, LFT is near normal.
Yes, sir.
So, and it is described as a small subphrenic collection where access may also be a problem. So you will have to use your discretion because this will have to be drained transpleurally. You don't want the pleural cavity to be contaminated by bile. So if clinically she has no sepsis, it is a small subphrenic collection, which may actually, if we see the image, which may actually be like a rim of fluid between the diaphragm and the posterior superior surface of the liver. I'm not sure whether you would just go by the image or whether you should base your decision based on the clinical condition of the patient.
Yes, sir.
It's 4 centimeters length, but width is 2 only. But as I said, maybe just a rim of collection. 4 centimeters width, but width is so may not drain, and location is also subphrenic.
Yes. Yes.
So you have done
I
an
would,
MRCP and it shows a type 3 biliary stricture.
yes, sir.
Because MRCP is not available, then what would you plan now? 2 months, patient is free of living. You have the clinical picture with you.
Yes, sir.
Patient. So what is your plan? You want to still wait or you want to go ahead?
No, sir. I would like to go ahead with definitive surgery, sir. Open Roux-en-Y hepatico-jejunostomy with wide anastomosis extending into the left hepatic duct, sir. If it is a type 3 injury.
Suppose
If this patient came to you at 1 month, okay, it's now 2 months. Just imagine this patient came to you at 1 month.
Yes, sir.
What would your plan? You would have waited or you would have operated that time?
So I would like to wait for 6 weeks after the surgery for all the inflammation to subside.
What inflammation?
Post cholecystectomy inflammation. That's about it. If there is this history of acute cholecystitis with frozen callets and all, so I expect inflammation around there. To be on the safer side, I would wait for 6 to 8 weeks.
frozen callot is not an indication or suggestion of acute, it is a suggestion of long-standing chronic cholecystitis. In acute cholecystitis, you will have edematous, friable, vascular tissues. There is a difference between acute inflammation and chronic inflammation leading to fibrosis. Anyway, going back to, so what direct question is, what is the appropriate timing of repair of a injury, especially one which is associated with, say, bile leak and biloma?
6 to 8 weeks from the duration of surgery, given that any collection has been drained and the patient is out of sepsis and is well nourished.
Yeah. So now you said that you will plan for surgery now, but suppose I say that we have done a PTVD-gram also, and it shows either it reconfirms that it is a type 4 or a not so good type 3 stricture. There is some contrast going into the left duct, but it's just a trickle and there is narrowing at the confluence. Does it change? Does it modify your plan? Would you do something else?
So I would still go in for a definitive surgery on this. During the anastomosis, I can include both ducts into the anastomosis if there is a type 4 injuries.
Do you anticipate any problems intraoperatively in a type 4 injury?
A type 4 injury, if there is a proximal extension, I would have to go deeper into obtain patent ducts on both sides.
So in
So,
any
sorry, say
type-
again.
Only lowering the hilar plate would not be sufficient, sir. And I would have to obtain the proximal ducts for adequate anastomosis, sir. I have to go into the liver for that.
so
What do you
in,
mean by go into the liver?
To identify the ducts only, sir.
So generally in a patient with a
Yes, sir.
type, what is your approach? So how will you start and how will you reach the right side? So where do you expect the challenge in a type 4?
Type 4 more on the right side only, sir.
So how will you approach?
Sir, I would initially lower the hilar plate, then along the umbilical this thing and take out. I'm not sure, sir.
so if you know that you are dealing with a type 4 or a bad type 3, the first thing which has to come to your mind is, and not every group may be doing, but we strongly believe that it should be done, is what I said, PTBC, pre-operative percutaneous transhepatic biliary catheterization. Now here we already have a PTBD, but if you recollect the film which was done, the tip of the catheter is not going down. It is going into one of the ducts horizontally. Therefore, it is important to get it remanipulated. And when you want to get a PTBC done or you want to convert a PTBD into PTBC, you have to request your IR colleague that the tip of the catheter should go to the hilum as close to the stricture as possible, because that will be the best way that you can identify the duct intraoperatively. And how to identify a right duct during the operation? You have to first get the left duct, open it, and see from inside. It is possible that if it is a bad type 3 or even if it appeared type 4, there will be a small opening through which you can see bile coming, and then when you probe it, you get into the right duct. So that is the easiest. Now, it is possible that you open the left, but you see a closed end. You don't see any communication to the right. That means they are really and totally separate. That is where the PTBC comes to your rescue. You can inject saline. If there is a small hole somewhere in the duct, you can see it coming. You can inject methylene blue stained saline. You can do a cholangiogram by putting a instrument or a clip at the hilum and see how much is the distance or depth from there of the tip of the duct. And next step would be what you meant by when you said that you go into liver. What you do is, you know that the right anterior sectoral pedicle lies in the gallbladder bed. So the duct is going obliquely. If you make a hepatotomy in the gallbladder bed at right angle to the expected direction of the duct, somewhere you will hit the duct. And fortunately, the anatomy of the biliovascular pedicle is such that the duct is most superficial. So as you divide the liver parenchyma in the gallbladder bed, close to the hilum, at a perpendicular to the expected line of the right anterior sectoral pedicle, you are likely to hit the anterior sectoral duct. And from your preoperative imaging, you know whether the secondary ductal confluence is free or not free. In most cases, it is likely to be free. Very rarely it would be involved. If it is involved, you may have to get two PTBCs placed, one in the anterior and one in the posterior. Because all students who are going to become biliary surgeons tomorrow must remember that it is very, very difficult to identify these ducts intraoperatively if you do not have these catheters placed. These catheters are very, very helpful. And therefore, you should have a very low threshold of catheterizing these ducts preoperatively if you have good IR support available. And last approach described by Dr. Miyazaki from Japan and surgeon from Mexico, where you do a hepatotomy. So between segment 4 and 5, hepatotomy, go split the liver open it like a book, and then you reach the right pedicle. But That is very, very rarely required. And what Dr. Yadav has said, that in any patient with biliary stricture, you have to talk of the preparation of the patient, which includes the general preparation as well as the radiological preparation before you go ahead and say that I would operate upon this patient. Kalay, you were saying something.
Yeah, I think so. As I was mentioning, the most important point you should remember is see, the hilar plate is basically the thickened Glisonian sheath which covers at the biliary system at the hilum. Okay. So what is easy to identify is on the left side, but once you identify, you have actually lowered the hilar plate, and that is in continuity with the right side ducts also. So you carefully follow it. Okay. In addition to whatever you have the catheter. But if you actually see in a kind of when you do an extensive hilar bile duct, so you can see even when there are multiple ducts, they all will be in the same plane covered by the thickened Glisonian sheath. Okay. So once you identify, so identify left side is the key, and then you just keep following the thickened sheath that will lead you into the right side ducts.
Yes.
So that's the most important thing you should remember.
So Venu and Kalay, we can take 5 more minutes and then leave 15 minutes for the other faculty to comment.
Yes, sir, I think.
Yeah, please go ahead.
No, I'm done from my side. So I think we can discuss. We have already nighted.
Venu, you have anything?
Nothing in particular. We can proceed to the comments.
So just briefly describe how you would do the anastomosis, the principles of a biliary enteric anastomosis.
Wide mucosa to mucosa anastomosis, side to side, with extension into the left hepatic duct, taking care that both ducts are draining adequately. Yes. Avoiding any areas of fibrosis, making sure all our bites are holding well. Sir.
What kind of anastomosis? What suture? Single layer, double layer?
Side to side anastomosis with interrupted non-absorbable sutures. 60 or 50 non-absorbable sutures.
Non-absorbable.
Yes. Sir.
Non-absorbable.
Non-absorbable or delayed absorbable.
So you would use proline, you would use silk, you would use nylon. They are the non-absorbable suture.
PDS, sir. Delayed absorbable. PDS, I would use.
PDS, non-absorbable suture?
Delayed absorbable.
What is the difference? Whenever you are asked how you will do the anastomosis, you should start by saying which two parts or organs are going to be anastomosed. So first you should talk about them. So you didn't use at any stage the word Roux-en-Y, loop, because some people would do a duodenostomy also. So you should say, second, yes, as wide stoma as possible. That would depend on the anatomy of the left duct. If the left duct is horizontal, has a long extrahepatic course, you can get a good diameter. If it is vertical, then perforce you will have to do with whatever you can get. So although most cases say 2.5 centimeter, but that may not be possible in all cases. So you get as large a stoma as possible. Third, it should not be to the fibrotic tissue. It should be to healthy duct. So if you have to go high into the left duct, into the right duct, then since we were dealing with the dipore stricture, you should have said whether you will end up having two anastomosis, separate anastomosis, which means two separate openings in the jejunum, or you can still afford to drain both the ducts, but it's a single opening in the jejunum. Whether there will be two separate ducts or whether they are close together so that you can do a septoplasty. And then finally, whenever you are asked about an anastomosis, you should always mention single layer, double layer, interrupted, continuous, what size suture, what suture. That is the complete answer. So don't just say, I will do a hepatico-jejunostomy. You must use the opportunity to answer the question to show your knowledge. The basic principle in any clinical exam is that you give the least opportunity to the examiner to ask as many counter questions as you can. So students, please send me a mail, vkkapoor.india@gmail.com. Write BDI or BBS in the subject of the mail, I will send you some of the publications which we've had from SGPGI on biliary injury and bile duct stricture, which will give you an idea about the philosophy of management. I think there are some questions from the students, some of which you've already taken, but Kalai or Venu, would you like to take the first? I request to all the students, please don't attend as anonymous attendee and PM. You should be putting your full name in the identity box. So there is a question from Dr. PM. You would like to take that, Christina? How will you manage if you detect a lateral injury or a complete transaction intra-op? Quick.
Sure. Depending on the size of the injury, if there's a good anatomy, I would prefer to do. There are two options. Either if it's a small lateral injury, which is not due to an energy device, end-to-end anesthesia or simple closure can be done.
Somebody's microphone is on. Can you please put it off? One microphone is on. Yes, please go on. Yeah, carry on.
A small lateral injury not caused by an energy device can be repaired primarily over stents. If it is a significantly sized injury, I would like to place a stent, leave a drain in situ, and plan for a delayed repair later on while optimizing the patient and treating any cholangitis if it occurs.
So I don't think we have time to go into details, but the first thing you have to mention is the expertise and experience of the surgeon. Everything else depends on that. In most situations, it will be a general laparoscopic non-biliary surgeon where all these things probably would not be advisable. So it all depends on that. Maybe we can request other panelists to come in, and if they want to take the questions which have been put in the chat by the student. DD? And Dr. Supe is there, Dr. Shastri is there.
Somebody is muting. Yes, sir. Good morning. There are multiple things have been discussed, but there are certain things which are very pertinent, which have been probably a little bit ignored. Like when you talked about early repair, so candidate must remember that even in a setting of a patient where there is only clip and there is no biliary fistula, there is no this thing. Higher injury has about 25 to 30% incidence of vascular injury. So until unless patient is having intense pruritus, which is a compelling force for us to go early, or other things can wait a little bit, and proper preparation of the patient might be very appropriate, because this is worse than any other thing, that is we are operating in a non-anatomical position. Second was about PTC with PTBD gram with MRCP. And we did one study this role of PTC in the era of MRCP. And we found that only in the case of internal fistulae, which are usually present with the duodenal fistulae, the PTC had shown any advantage. Otherwise, all other things are only just we think conjecture and had not helped more. I'm not talking about putting a catheter before the surgery. So third important point is when you talked about how to do a biliary intake anastomosis, I think it's very, very important to talk about preparation. So coagulopathy and sepsis. These are the two very, very important things. Coagulopathy, I will go up to the extent, sepsis, I will go up to the extent of doing a CRP level also. Patient should be absolutely free of the sepsis. And there should be proper discussion with the relatives in a type 4 injury. And one interventional radiologist or your friend, we can help on the table when you are not able to find the duct at the time of the exploration. This has happened with us when you are working in a high volume center. One day will come, there is so much of frozen areas, especially in era of endoscopy, doing multiple trials nowadays. So one friend should be there who can help to identify the duct, help you in puncturing the duct. So these are the very important pertinent points, especially in a higher injury. One has to remember, and always get help of somebody. Ask your friend getting ready once you are going for type 5 and type 4 injury. So these are the certain important points I thought they were missing in the discussion. Thank you.
I think there are specific questions which we can answer. One is, there was one on, will you do a PTBT to control an external biliary fistula? So that is generally not an indication to dry it up and make patient ready for surgery early. So usually that is not the indication of a PTBT in external biliary fistula. So generally, only in this type of early setting where there is cholangitis or for identification of duct, as mentioned by Dr. V.K. Kapoor, otherwise that's not an indication. About if you find the liver as cirrhotic, so usually, we know it by preoperative imaging. So once well-established cirrhosis, you can actually make out from preoperative ultrasound or the cross-sectional imaging. But if there is fibrosis, and that usually does not change the line of management, because biliary, even to some extent, there are some studies which show the biliary cirrhosis tend to revert with the drainage. And indication for hepatectomy in bile duct injury repair other than atrophy, hypertrophy complex. So even in atrophy, hypertrophy, the hepatectomy is not routinely indicated unless you, like if you can establish a good drainage of even the atrophic segment, you go ahead with the drainage. So hepatectomy is only when you can't establish a good biliary drainage of the atrophic segment. PTBT. Yeah, Dr. Venumadhav, please.
For a sectoral duct injury which has not drained and is patient recurrent cholangitis, there is a rare scenario where where hepatectomy is indicated. Yes.
PTBT present, PTBT always required, not mandatory. For example, if you have MR which gives you all the information, may not be required. But in this case, because MR did look like the ducts are separated, so you can, since you have PTBT, you can confirm that finding, which will help you in intraoperatively. I think we have early repair CCTs, yes, that we have answered. It's required, and
CT scan is required in biliary injury, mostly for collections. Of course, it's required for assessing vascular injury and medical legal purpose also, but the main indication is for collections. Yes. I think we have answered all the questions.
Yeah.
Yeah, so students are often asked about what is the role and importance of vascular injury and why should we evaluate for it, even if you are doing a delayed repair. There are two reasons which come to my mind. One is that if you have a bad stricture, which means a type 4 or a bad type 3, and there is an associated vascular injury, you keep a low threshold for a possible hepatectomy, especially if you don't find the duct, or you find the duct, but it is looking fibrotic, and you know that even if you are able to do the anastomosis, there is a very high chance of a restricture. So you are mentally and logistically prepared for a possible hepatectomy, a change of decision intra-op. That is one reason. And second is more from a medical legal point of view, because as Dr. Yadav was pointing out, that in lap chole injury and in higher injuries, there is a very high incidence of a big vascular injury, especially the right hepatic artery injury at the time of lap chole. So once you document that, then it saves you from the allegation that it was you who injured the vessel during the repair, which is also a possibility because the right hepatic artery is encased in the fibrotic process of the stricture, and while trying to approach the duct, you may cause an injury to it. So these are two reasons why the documentation. Otherwise, presence or absence of vascular injury does not change your management. There are studies which show that vascular injury is a risk factor for a recurrent stricture, or at the same time, there are others which show that it doesn't matter. So from a practical point of view, presence or absence of vascular injury does not change your management. You would still repair if you can repair it. It only decreases your threshold for a resection. liver resection if you can't get a duct or if you can't get a good duct. One more point I wanted to say, but I forgot. Yeah. Dr. Shastri, Dr. Supe, any comments?
Dr. Shastri mentioned his message.
Very nicely done. Actually, I have no message. Only I wanted to reinforce what Dr. Kapoor said, that today we are getting patients for early repair. But if everything is clean, then only you should do it. Because otherwise you can always land up in trouble. But otherwise, what factors he said, no, everything should be clean, patient coming, no jaundice is there, clips are seen, no collection. Such patients, if there is no vascular injury, we normally do it now early. But otherwise, I think delayed repair is still the key.
So, Kalai and Dr. Venu, we can close the session if there's nothing else.
Yes,
Sir, I have a doubt, sir.
Yes, please go ahead.
Sir, in this patient, what would be the role of a transanastomotic stent or a proximal biliary drainage after the anastomosis, sir?
Yeah, so the Johns Hopkins Hospital philosophy used to be, when Dr. Cameron, Dr. Pitt and everybody was there, that they used to place the PTBCs in all cases and stent all cases. But we at SGPGI had a difference of opinion with them. We did not believe in selective PTBC and routine PTBC and routine stenting of the anastomosis. We always used it selectively, and selectively would be when overall you are not happy and satisfied with the anastomosis and you feel that this anastomosis is likely to restricture, which would usually be the case in a bad type 3 or a type 4, when you know that there is some fibrosis on the right side where you've taken the sutures. In those cases, we will keep the stent, and these stents will have to be kept for long, minimum 6 months, maybe even 12 months, which means that they need to be exchanged from time to time, every 3 to 4 months, and they can be kept. Another philosophy which the Japanese surgeons follow, not in biliary stricture, but in any biliary enteric anastomosis done for other procedure, is what is a proximal biliary drainage, which means that the tube is kept proximal to the anastomosis, the purpose of which is to decompress the biliary tree, which is a proximal biliary drainage. And the purpose of aim of that is to reduce the incidence of leak, and if a leak occurs, to reduce the side effects of the leak, like a proximal stoma. So those proximal biliary drains, you do a cholangiogram at an appropriate time, and if you show that the anastomosis has healed, there is no leak, you can remove them early, maybe at 2 to 3 weeks. So that is the difference between proximal biliary drainage and transanastomotic stents. So we would use them selectively, not in all cases, and that is where these PTBCs will be very helpful, because trying to place a transanastomotic stent transhepatic intraoperatively sometimes becomes very difficult and can be traumatic also. Okay, thank you, Christina. Thank you, Kalai and Dr. Venumadhav and all the other panelists. I think, shall we, IIG team, shall we close the session?
Yes.
Okay. Okay, thank you.
Thank you.
Thank you.
Thank you.